Purva, can you hear?
Yeah, I can hear you. You all can hear me, no?
Yes, yes, yes. Yeah. So, so welcome to this month IAPPHO nursing session of
Dharma,
December
you want me to
2024.
start?
Yeah, yeah. I'll just give you an introduction and then you can start. Can you hear me? Can you hear me?
Yes, ma'am, we can hear you. Your sound is,
Sir.
your voice is clear.
Sure, sir. Thank you. I think Dr. Purva's network is a bit unstable.
Hello. Hi, Dr. Purva. You can switch off your video if there is a network issue.
Yeah.
ऐसा तो कैप्शन आना चाहिए हालांकि
I think, sorry, I got disconnected, I think.
Yeah. You're back now. Thank you so much. So, welcome everyone to this month's nursing session by the IAPPHO team. So, I sincerely thank the team from BJ Wadia Hospital for Children at Mumbai, Dr. Purva and Dr. Vijaya Gauri. They have agreed to talk on immunodeficiency in children, how to recognize the signs and how to care for them. What are the particular aspects that needs to be specifically known about children who are immunocompromised? So Dr. Purva is a consultant at the Department of Pediatric Hematology Oncology at BJ Wadia Hospital, a very good friend of mine. And I hand over to you, Dr. Purva. For the next 40 to 45 minutes, I request you both to talk on the topics. And then we'll have the last 5 to 10 minutes for discussions if there is any question. And I request all the delegates to post your questions on the chat box as and when you get the doubts. We will discuss everything at the end. Thank you so much. Over to you, Purva.
Yeah. Thank you, Dharma, for inviting us. And without much delay, I'll start with the topic. So the topic for today is immunodeficiency in children and how to recognize the signs. So when we look at immunity, there are two types. It is an innate immunity and the adaptive immune response. The innate immunity is like the first line of defense which occurs. And so then whenever there is an infection or any infiltration, the innate immunity acts first. So it does not take time to respond. So that consists of your dendritic cells, macrophages, natural killer cells, complements, neutrophil, eosinophils, basophils. Whereas once the adaptive immunity, which is the slow response, which takes some time to develop and can be against a typical infection, and it can target that particular infection, takes some time to develop. So what is immunodeficiency? So immunodeficiency can be a primary or an acquired. Primary can be due to innate, like because of phagocytes being involved, that is your neutrophils being involved, or your neutrophilic function, the monocyte macrophage system, or because the complement defect, which is a part of the innate immunity, or it could be because of the adaptive immunity being affected. So a T cell defect, a B cell defect, or a combined defect. In acquired causes, we will see drugs like chemotherapy, immunosuppression, chronic infections like HIV, and malnutrition. So how common is PID? So close to 250 different forms of PID exist. 70 to 90% of PI sufferers remain undiagnosed. 6 million people worldwide may be living with PID. And 1,200 suspected people with a genetic primary immunodeficiency that significantly affects their health. So when to suspect PID, how to recognize the sign in children? So everyone gets sick, but how often is too sick? So we need to learn to spot the warning signs of PID. So you have the Jeffrey model criteria. So this gives us 10 warning signs of primary immunodeficiency. So if someone has 4 or more new year infections within a year, if there are 2 or more serious sinus infections within a year, 2 or more months of antibiotics with little effect, 2 or more pneumonias within a year, the infant is not gaining height normally. There are recurrent deep skin abscesses or organ abscesses, whether there is a persistent thrush, there is a need for intravenous antibiotics, 2 or more deep-seated infections, or a family history. So, in short, if we go to see anybody who has an infection which takes a very long to clear, infection which is at an uncommon site and with an uncommon organism, is something where we should think about immunodeficiency. So when we talk of immunodeficiency, now it has changed from a PID to an inborn error of immunity, because it not just causes infection, it can also cause immune dysregulation causing autoimmunity, or can even be a cause of malignancy. So when we look at the infection profile, it depends upon what is the type of immune cell which is affected. If your B cells are affected, you are likely to get an infection with pneumococcus H influenzae. If your phagocytes are affected, you can get gram-negative infections like E. coli, Klebsiella, Serratia, Salmonella, which are opportunistic organisms, gram-positive, like Nocardia, Listeria, fungus like Aspergillus candidiosis. T cells, if they are affected, you can get mycobacterial or various viruses. And there are some which are common. So we will look at all of this through some common case scenarios, which are the common signs. So the first case, this is a 5-month-old female child. She's born of a non-consanguineous marriage. She was a full-term child born out of having a good birth weight, cried immediately. She was developmentally normal, exclusively breastfed, and she received her vaccines. So this child at day 15 developed a breast abscess. She required antibiotic for 14 days. At 1.5 months, she developed a sciatic scalp. Then she developed an erythematous rash. At 2 months, she had loose stools and she was not gaining weight. So we can see a perianal rash. She required a hospital admission for IV antibiotics. When a CBC was done, it was seen that her HB was still okay for her age, but her ALC was quite low. She developed an enterohemorrhagic enterocolitis. She developed a Klebsiella, and there was no response to IV antibiotics. And then she developed a Shigella dysentery. So when she came to Wadia at 5 months, she had chronic diarrhea, cold and cough. She had a BCG scar, but she had respiratory distress. She had bilateral crepitations. Her weight and height were less. So she had this kind of a rash. She had this mucocutaneous candidiasis. Again, here the ALC was low. The HB had also dropped further. And when we saw her X-ray, what you can see, there is no thymus. So in this case, should we suspect a primary immunodeficiency? So yes, she had an early onset of multiple infections. She had this rash, she had failure to thrive, a low lymphocyte count, a bacterial infection which was not clearing with antibiotics, and she had an absent thymus and tonsils. So when such a thing is there, we are suspecting, we do a lymphocyte subset analysis. So this is the normal percentage in children. So when we saw here that her lymphocytes were low and so were her B cells and T cells, so NK cells were normal. And her immunoglobulin, she had a pan-hypogammaglobulinemia. So we suspected something called as a severe combined immunodeficiency with T and B cell negative and NK cells were present. So this is something which was initially called as a bubble baby, where when the child was first time diagnosed with these many infections, the child was kept in a kind of a bubble to protect him from all kind of infections. So because T cells are affected, cellular immunity is affected, they can have failure to thrive, oral thrush, chronic diarrhea, recurrent pneumonias, BCG adenitis, BCGosis. They could get a maternal GVHD that could cause eczema, splenomegaly, transfusion-associated GVHD. The microbes which we commonly see are viruses like CMV, adeno-influenza, rota, fungal infections with pneumocystis jirovecii, candidas, protozoas. And because of the B cell, which is antibody mediated, you can get sinopulmonary infections, skin infections, enteroviral infections. So there can be a number of infections which can occur, plus with encapsulated bacteria. So to conclude, when you think of SCID, when they have an early age of onset, it's a pediatric emergency. You think of clinical, when there are opportunistic infections in infancy, failure to thrive, persistent diarrheas, pneumonias. There could be a family history of an early infantile sibling death. Investigations will show ALC less than 3,000, absent lymph nodes, thymus, tonsils. They will have low T, B, NK, and can have either of the combinations, immunoglobulins, and can have low T cells. So SCID is something which can present with such kind of symptoms. And a genetic testing would be finally required. So the next thing, now we look at this child. You can see that this child has a kind of a face which has an underdeveloped chin. The nose is prominent. The ears are larger. So this is a DiGeorge syndrome. They have facial dysmorphisms. So they can have hypertelorism, narrow palpebral rims, coloboma, small auricles. The ear ellix can be folded. They can have a nose with a broad root. There can be root hypoplasia, small mouth, and palatal anomalies. So along with that, they also can have an immunological alteration like thymic aplasia or hypoplasia or a cellular and humoral abnormalities. So this is again looking at a phenotypically child who looks like DiGeorge, they can have immunological abnormalities. So we look at another case. This is a 4-month-old girl. She was first by birth swelling since 10 days. There was perianal redness, pain since 5 days, but there was no pus discharge. We can see here, there is a redness, but there is no pus discharge. In fact, in spite of having so much of infection. So here her total WBC count was high and an ANC was very high. So here when you see something, a peripheral smear was showing neutrophilic leukocytosis. So the salient feature here was infections, but there was no pus at the site of infection. When such a scenario occurs, we have to think of something called as leukocyte adhesion defect, where they have a phagocytic defect. So you can get a number of infections which are due to gram-positive organisms, and they can have no pus at that site. So omphalitis, they can have gingivitis, and they can have such kind of an abscess without a pus development. So mutations, there are a number of patients which can have congenital neutropenia. So they can have low neutrophil count, because of which they can have symptoms. So we will not go into much detail of this, but they will have a similar, this with a phagocytic defect. And few of them can have like Fanconi-like features. So this is something that you see, like we saw in our first child. This is a chronic mucocutaneous candidiasis. So where do you see it? You can see it in combined immunodeficiencies, patients with children with phagocytic defects, something called as EPSID, CARD9 and STAT1 deficiencies. So when you see this picture of the child, this child has a BCG scar which is present and which has developed a BCGiosis, also has a chronic mucocutaneous candidiasis, has nail abnormalities, along with that has a cutaneous rash. So this is a BCG, this is a cutaneous BCGiosis. Along with that, this is a child who has developed, you can see in the bones, you can see that there are multiple lesions and they developed a disease, tuberculosis of the bones. So these all defects you can see with the Mendelian susceptibility to mycobacterial diseases. So here they have a susceptibility specifically to mycobacteria, non-salmonella, which is non-typhi. Some of them can have chronic mucocutaneous candidiasis. So what we saw in this previous one, if they have something which is a multifocal tuberculosis of the bones, you can have something as the partial defect in the interferon gamma pathway. So then the other thing we can see is EPSID. So EPSID is something which is, so EPSID is an autoimmune polyendocrinopathy disorder where you can see they have chronic mucocutaneous candidiasis. We can see an extensive keratopathy, which is secondary to keratoconjunctivitis. There is candida cheilitis. So these are all things which we are saying because only when you know that you can suspect. So all these things, they can present with chronic mucocutaneous candidiasis. And along with that, you can also have adrenal insufficiencies, hypothyroidism, hypoparathyroidism. So because of adrenal insufficiency, they may just have skin hyperpigmentation. So moving forward to the next case, this is a 1-year-old child. He had a disseminated fungal infection since 1 month. He had recurrent respiratory tract infection since 3 months. So here now that we are knowing that we can see that, this is a child who's developing an infections at a very early age, fungal infections and respiratory infections, when we saw that he had an AEC which was very high. an absolute eosinophil count, which was very high, and a serum IgE was high. So this is something which belongs to the spectrum of hyperimmunoglobulin E syndrome. Initially, it was known as an autosomal recessive. Now it is due to a Dockett deficiency. Now it is known as DOSID, which is a combined immunodeficiency. Here you will not see any physical anomalies, but they can have recurrent viral and fungal infections and can be prone to malignancy. Similarly, this is an autosomal dominant hyper IgE syndrome due to STAT3. You can have a child who develops these multiple cold abscesses. So this F is the one who developed these cold abscesses. G is a boy. You can see this typical classical facial features, which are there, coarse facial features. They can develop alopecia areata. They develop retained primary dentition also. Along with that, they can have hyperextensibility of genes of joints. They could develop staphylococcal cold abscesses at presentation. So when you see something like this, then you know that this could be something what is suspected. So this is a 6.5-month-old male child who presented with eczema. You can see this kind of eczema since day 15 of life, had melena on and off since 1 month, history of recurrent otitis media and respiratory tract infection. So along with having otherwise a normal CBC, the platelets were low and a mean platelet volume was low. When we saw peripheral smear, we saw that the platelets were actually like dust. So now this child is a male child who comes with an early age of onset, having bleeding, thrombocytopenia, low MPV, microplatelets on peripheral smear, having recurrent otitis media, some pulmonary infection. So this is a syndrome called as Wiskott-Aldrich syndrome, which is an X-linked disorder and having a combined immunodeficiency. So looking at the next case, see this is a GATA2 deficiency. So people with this can just present initially having a lymphedema, deep vein thrombosis, having genital warts, So looking when you see somebody who's developing a myelodysplasia, an MDS, an AML, and also having a lymphedema, having monocytosis, monocytopenia, you can think of a GATA2 deficiency. So looking at the next case, this is a 15-month-old girl. She presented with fever, multiple episodes of convulsion, having a hepatosplenomegaly, silvery gray hair, and pancytopenias. So when we see this is a child who has a Griscelli syndrome type 2. So on clinical examination, we can see this hair. We can see that the hair mount, when we see, there are these melanin pigments which are there. There are small clumps, large clumps of them. So this is a child who has developed an HLH and having pigmentary dilution disorder. So when in HLH, they have prolonged fevers, unexplained cytopenias, hepatosplenomegaly, hypopigmented hair or skin, rarely rash, lymphadenopathy. They could present with fulminant liver failure, isolated CNS manifestations, or a prior or family history. The other pigmentary dilution disorders that you can see is a Shediac Higashi, where you can see that the child again has a silvery hair. The hair mount is showing some clumps. And here, especially in a peripheral smear, you can see these clumps of granules which are present. So other thing you can see is a Hansi Pullak, who could also present with a PID and could have again a hypopigmented. So these are three disorders which are pigmentary disorders and can have immunological as well as hematological manifestations. So going forward to the next case, this is a 10-year-old boy came with history of episodic bilateral cervical lymphadenopathy, who now has AIHA and a hepatosplenomegaly. The DNT turned out the double negative T cell. So here we thought of something called as autoimmune lymphoproliferative syndrome. They have early onset or chronic course. They can have autoimmunities, like in our child. He had a AIHA, also had a non-malignant polyclonal lymphoproliferation, so had bilateral lymphadenopathy and increased susceptibility to malignancies. So whenever something like this, you have immune-mediated cytopenias, lymphocytic infiltration of non-lymphoid organs. So you get hepatosplenomegalis, you get lymphadenopathies, and you have chronic infections like EBV. But your double negative T cells are normal. Then you can think of other ALPS like disorders, which can consist of a multiple spectrum of disorders who can present with a similar function. Some of the children develop EBV, chronic lymphoproliferation, and they can also develop an HLH. When they do, they can have certain underlying disorders. If it is a male child, it could be something like an X-linked lymphoproliferative syndrome. There could be a number of disorders which could predispose the child to an EBV infection. So other thing that you can see as a part of immunodeficiency are autoinflammatory disorders where they can present with periodic fevers, having neutropenic rashes, urticaria, mouth ulcers, serositis, arthritis. They could also develop lymphadenopathy, hepatosplenomegaly, and also have neutrophilia with elevated acute phase reactants. So when you have something like this, you could also think of autoinflammatory disorders. So the next thing is this child has, you can see a very red scalp and a very dry skin, along with having teeth abnormality. So this is an anhydrotic ectodermal dysplasia, a condition which is characterized by dry and thickened skin, conical teeth, absence of sweat glands, and thin and sparse hair. So this is something called as a immunodeficiency, which is an X-linked disorder due to a deficiency in the NF-kappa beta pathway. So what we saw was a wide range of different disorders. When you go head to toe, you will see that almost every other symptom system is affected. Very few have phenotypic abnormalities. So the take-home message in this is you suspect, whenever you're taking a detailed review, you look at what the infection profile, is there autoimmunity, is there a history of not just in the family, autoimmunity, not just this particular child, but also in history. When you're doing a physical examination, do a complete examination. Look at the hair, look at the eyes, teeth, skin. So every system can have some or the other abnormality which can help you diagnose and help you suspect. So the red flags for PID, just looking at the infection profile and looking at a CBC can guide you. Whenever possible, always isolate an organism which can give you an important clue to the type of PID. Infections may not always be the primary presentation. Sometimes you can have only autoimmunity, sometimes an infection, or sometimes you can have all three together. You suspect a primary immunodeficiency. Look at a detailed family history can give you a clue to an early diagnosis. So why all of this is important? Only when you diagnose early, you can give treatment at the appropriate time. Something like a skid, if you diagnose very early, within the first few days, they can go for a transplant without much comorbidities. So whenever they are diagnosed on time, your morbidity is lesser and mortality is also lesser. So the most important thing is that I will never know if your mind does not, I will not see what your mind does not know. The aim of this was to just brief that such a thing can happen. All these diseases may be rare. Hope should not be, because if you diagnose on time, and they come much better in life. So I would like to end my presentation with acknowledgements to Dr. Mukesh Desai, Mr. Prasad, Dr. Behari, Department of Inborn Errors of Immunity, with whom we work in very close collaboration so that we work together, learn together to see all these cases. And this is our department. So with the backbone of our department, the nurses, the social workers, the nutritionists, all our doctors, so that we can treat all our children together. Thank you for a very patient listening.
Thank you so much, Dr. Purva. It was a detailed discussion. So I think the pictures are very good and explanatory. So basically, she has made it very clear that it is called the inborn errors of immunity, not the primary immunodeficiencies anymore. And the any child with all these diagnostic clinical features, it should make us think of a primary immunodeficiency, because most of the time we get the diagnosis very late. They come with advanced infection, so that stabilizing them and then getting to them to a specific treatment like bone marrow transplant becomes a huge challenge in developing countries. So oral thrush, failure to thrive, recurrent pneumonia, and all these nail changes, dysmorphism, these features, the gray hair, whatever she has shown in the Grisely syndrome. All these things should alert us towards further evaluation. So that's a very good learning message. I request Dr. Vijaya Gauri to take over and do her presentation. Thank you.
Thank you so much, Tharani. Yeah, is it visible? Thank you for this opportunity.
Yeah, it's visible. Yeah.
So many things have been covered by Dr. Purva. So I would like to say, tell you a few things. There are two arms of immune system. We are just reiterating what has been told to you already. So that's an innate immune system and an adaptive immune system. And what is an innate immune system? The innate immune system cells consists of neutrophils, eosinophils, monocytes, and the natural killer cells. They are innate in origin. That is, we inherit them from our parents. So they are ancient. They are environmentally ancient. We have inherited it. This is the first line of defense against any infection. And adaptive is something which our immune system learns over a period of time as the dendritic cells present the antigen, and we learn to adapt to our surrounding by producing antibodies and certain other cytokines and chemokines take care of all the infections by activating the phagocytes as well. So that's an adaptive response. So we as human beings live in an environment which is teeming with microorganisms, and the innate immune system constitutes the first line of barrier, the rapid response mechanism to prevent microbial invasion. Its components are inherited, and the host defense components are evolutionarily ancient. All of us have the same thing. Okay. So why are we calling now that this as an inborn error of immunity? Why are we not calling it a primary immune deficiency? There has been a nomenclature change in the last few years. That's because you can see that it's like the five fingers. So PID is not just restricted to infection. Now we have the armamentarium has extended, and we have an autoimmunity, malignancy, autoinflammation, and the phenocopies, all five of them together. Therefore, now it's not just a primary immune deficiency, but it is inborn error of immunity. Why do you call this? It's not just infection which is responsible for all the features which come with the patient, but there can be an autoimmune mechanism as well. So in our cohort, we have almost 67% of our patients who presented to us with Evans syndrome. Evans is autoimmune hemolytic anemia and autoimmune thrombocytopenia, as well as extended Evans syndrome, which also includes autoimmune neutropenia. 67% of our patients had a monogenic error which was responsible for that kind of an autoimmunity. And when we went on to look for other autoimmunity in these patients, we found that many of them, almost 42% of them, had polyautoimmunity. That is, they had more than two autoimmune mechanisms responsible for this kind of defect, and they had a monogenic error. Okay, so as we already said that you can have a malignancy. Why malignancy is an immune defect or an inborn error of immunity? If the malignancy comes at an abnormal age, at an abnormal site where you don't expect that to be there. Say, for example, there is a marginal zone lymphoma of the tonsil, of the tongue. You expect it in spleen, and if it is there in some other site, if you have a recurrence of malignancy, and if it is a refractory malignancy, or if there has been a change or there has been a lineage switch, or there is a Richter's transformation, we call it, then in that case, we call it, we suspect that there's an underlying immune deficiency, which is, or a genetic defect, which is responsible for this kind of malignancy. Apart from that, you would have heard of a lot of people saying that our children or my child has got a lot of fever, there is some arthritis, some arthralgia, some ulcers, in redness of the eyes. All those children are actually suffering from autoinflammation. Therefore, there has been a change in nomenclature from what was just a PID to is now to IEI. Okay. So is IEI rare? Actually, it is not. So screening for IEI is not available everywhere. Barring few conditions like DiGeorge or syndromic PIDs, there are no classical physical features. When the baby is born, I can say this is a primary immune deficiency child. Family history may not be present. This would be a firstborn child. There is an extensive use of antibiotics, and many of them mask the classical presentation. It's often considered rare and therefore not investigated. That's again a fallacy on our part. And the awareness about the availability of the diagnosis and methods, diagnostic methods and treatment is also not there. As a result, we consider IEI rare, though actually it is 1 in 1,200 is the possibility which Dr. Purva shared, which is less than what I would say hemophilia is. Hemophilia is 1 in 4,500, and we are calling inborn error of immunity as 1 in 1,200. Okay. So nursing officers, why is it that we need to talk to all our nursing people? It's because nursing officers are first line of defense in patient care. It is similar to, you are like a border. You can come across microorganisms, you can identify the microorganism and tell us that what the case is. So you are the first line of defense for the patient care. So here is a child who, this is a small case, and then I would go on to discuss what all we need to ask. This baby was born of a third-degree consanguineous marriage and had a history of sibling death. And that baby had died at 8 months of age, was a female baby. And that baby also had repeated infections since 2 months of age. What if this baby is born in your hospital? What are we supposed to do? So as a nursing, so doctors can spend half an hour, 1 hour with the patient, but it is a nursing staff which spends most of the time with the patient. So you need to ask about the antenatal history of the mother. Has there been any history of abortions, recurrent abortions, which they may not tell us in one go? So is there a history of recurrent abortion? If there is a history of extended family having a similar complaint, has there been a male or a female baby loss or an infant loss with recurrent infections? Was this baby who died at 8 months of age required an NICU stay, had a pneumonia or a respiratory distress, and the X-ray was not improving at all? Did the oxygen requirement remain for a long period of time? Was this baby also in the hospital for a longer period of time for a high total WBC count, as Dr. Purva had shown you? And was the cord fall delayed? Was the cord fall delayed? Was there a oomphalitis? Now that is leukocyte adhesion deficiency. There will be a delay in cord fall. We all know that phagocytes are responsible for the cord fall. So if there is a phagocytic defect like leukocyte adhesion deficiency, these phagocytes are unable to come from the bloodstream towards the cord. So if they cannot come towards the cord would remain there for a longer period of time. It may get infected and the patient will have oomphalitis as well. Is there a vaccination history and associated complications? You can get vaccination on the thigh. If there is a BCG site infection, something like a BCGitis, which had remained there for a very longer period of time, developed an left axillary lymphadenopathy or a supraclavicular lymphadenopathy with some pus discharge. That's also very important. Any abscess at the vaccination site. These are the histories which our nursing officers can ask our patient and the family members. History of failure to thrive in the baby, both growth and development. There might be failure to thrive as far as growth is concerned. The child might not be gaining weight, but there are so many children who might not be developing also properly. So there might be certain immune deficiency or inborn errors of immunity, which is not just associated with failure to thrive, but they are associated with developmental defects also. Is there a history of rash? Example is, there was a rash, Dr. Purva had already shown you, that was a rash of BCGiosis. The child had disseminated BCGiosis and the child was a severe combined immune deficiency. That baby also had a thrush. Oral thrush in severe combined immune deficiency, mainly because they have both T and B cell defect. So your body is unable to handle all kinds of organisms. Even the BCG vaccine, which is a live vaccine which was given to the child, had disseminated and also had a skin rash. The baby had a thrush because they have a T cell defect and they cannot handle the candida infection also. That same BCG site inflammation also caused an adenopathy. So the baby also has got BCG adenitis. Such children have multiple hospital admissions. So these kids also received rotavirus vaccine, oral polio vaccine, and they went on to develop rotavirus or polio, vaccine-associated poliovirus diarrhea. And they continue to disseminate this infection to all the kids around them. We are not aware about those children who are getting affected. And those children will become carrier because they are not immunocompromised. And they will transmit the infection to this baby, our baby who is a SCID. So that history of hospital admissions, a chronic diarrhea, as was seen in the SCID child, which Dr. Purva presented. History of pallor. The pallor is a very important indication that the child can come with. A child with a Wiskott-Eldridge syndrome would have bled. There would have been melena. He's a small baby. He's an infant. And if he bleeds from any side, like melena, if it has been going on for a longer period of time, and the child comes with marked pallor, there can be a petechial spots on the body, which the patient may not identify. But as a nursing staff, you will be able to pick it up better. And if the child has got an autoimmune hemolytic anemia, the child is actually hemolyzing and the child will have marked pallor. And history of skin or soft tissue abscesses. So these skin or soft tissue abscesses, as was shown by Dr. Purva in a hyper IgE syndrome, these infections are Staph aureus infections. They can come with soft tissue infection that is seen in a hyper IgE syndrome. A phagocytic defect also comes with multiple skin or soft tissue abscesses, as seen in leukocyte adhesion deficiency. It can be also seen in severe congenital neutropenia. They can also come with joint involvement, which can be an osteomyelitis. So in congenital neutropenia, it's usually a salmonella osteomyelitis, while in MSMD, Mendelian susceptibility to mycobacterial disease, it's a non-typhoidal salmonella. And if CBC is available, kindly look at the hemoglobin. And if the HbA is low, we need to ask for reticulocyte count. If we are not going to ask for reticulocyte count, it's actually not right. We don't know what bone marrow is doing. And look at the absolute neutrophil count and absolute lymphocyte count. Look at the absolute values, and the nomograms are available with most of the hospitals. And for age, we can compare it with the nomogram. So this baby again had an absolute lymphocyte count of 1,000 and was diagnosed as a case of SCID. There was a positive family history. The ALC was low, and SCID is a pediatric emergency. Now, live vaccines was given to this child. This baby was again admitted with respiratory distress. There was failure to thrive as well. Look at the thrush, look at the BCGiosis, and look at the absent times. Okay, so when these patients come to us, and if they go on discharge, as and when they go on discharge, we give them the patient information leaflet. This is very important. So children with either suspected or a proven PID, suspected because exome sequencing takes almost 4 weeks, and if the baby is fine, we discharge the baby home. So what are the precautions that they are supposed to take? The visitors with cold and cough, cold sores, any diarrhea or vomiting, or any kind of illness should not visit the baby. The baby is a suspected immune deficiency. Those with diarrhea and vomiting should avoid contact for at least 48 hours after recovery. Adhere to the strict hand washing with an antibacterial soap at home, including all visitors. Avoid crowded and busy areas such as shopping centers. Baby should not be taken out. Bottled mineral water is not allowed. The best is potable drinking water that needs to be boiled. Okay, and allow it to cool. Also, flushing of NG tubes or doing anything or making any drink for the child has to be boiled and cooled water. Water can be boiled and kept for 24 hours if the container is being used to store the water, has a lid. This can be stored in refrigerator or at room temperature. Bottle feeding, strictly avoided. Caretaker to use the face mask if he or she has got an infection. Child with a pyrexia, that is temperature more than 38 degrees Celsius, breathing difficulty, diarrhea and vomiting, or rashes should be taken to the hospital immediately. Carry your current prescription and previous medical reports to the hospital. This is something which we always tell them. And this needs to be noted by all my nursing colleagues, because these are the things which you are also supposed to tell them when they are going on discharge. So what are the instructions for the local hospital? This is also handed over, because many of them cannot tell the local hospital people what was conveyed to them. So the instruction to the hospital is, please contact us urgently. We give their mail, we give our phone number, our mail ID. If the child is febrile or unwell, the investigation that needs to be sent, the broad spectrum antibiotic that need to be started. If symptomatic for respiratory infection, do a X-ray test. X-ray test can pick up a PCP infection. We will get to know looking at the X-ray if they can send it on WhatsApp. We can see a necrotizing pneumonia and we can suspect a CGD. We can see a pneumatocoel and we can suspect a STAT3 or a hyper IgE syndrome. And there's so many things which we can actually identify looking at the chest X-ray. And absent thymus, of course, can be picked up always. No probiotics. Probiotics are live bacteria. No probiotics. The baby needs to be transfused only and only irradiated blood and blood products. Okay, that's extremely important. No immunizations to be given till we have a final call on what is a diagnosis. At least do not give live vaccines like oral polio drops to the patient and healthy kids at home. Rotavirus vaccine, oral polio vaccine, BCG vaccine. When the baby is born, these need to be avoided till we have a diagnosis in hand. If we have an early sibling death, and now this baby is the second born baby, let's wait for the diagnosis before we give the live vaccines. So this was already told to you. So this is Jeffrey model criteria. So, but how often is, too often is a very important thing. So this is again a baby who has been symptomatic at 7 months of age with a infection, and he also at 9 months had a culture positive E. coli meningitis. When he got admitted to Vardia hospital, there was a history of H influenza meningitis in an elder sibling who was already immunized. So how can somebody who is already immunized develop a H influenza meningitis? That's a very important question. So if somebody has developed an infection, means the B cells in the body are non-functional and therefore they are unable to produce the antibodies against it. Okay. So when this child with E. coli meningitis came to us, we found out, we sent his LSSA, we found out that his B cells are 0. What is the easiest way of identifying that this would be a B cell defect? Not LSSA, but just do a total protein, look at total albumin and globulin. And if the globulin is low, we know that we are dealing with a hypogamma or a gamma globulinemia. Here we did a immunoglobulin profile for this child and everything was low, that is pan hypogamma globulinemia. So we just in a child, past history of a sibling death, H influenza meningitis in the elder sibling who was already vaccinated. How many times do we see E. coli meningitis? Just look at the globulin. And if the globulin is low, we know that we are dealing with a B cell defect. And what is the easiest way of identifying? Open the mouth of the child, look for the tonsil, and the tonsil would be absent. Look for the child is a lymphoid organ. Dr. Mukesh Desai always says child is a lymphoid organ. If the child doesn't have lymph nodes, who else is going to have it? If the child doesn't have lymph node, we are dealing with A gamma globulinemia or a hypogamma globulinemia. X-linked high gamma globulinemia is a X-linked condition, and hypogamma, many of the A gamma globulinemias, there are other mutations which are autosomal recessive in nature. These kids need to be treated with IVIG at 400 mg per kg lifelong. They are on cotrimoxazole and azithromycin prophylaxis, and other male siblings in the family to be screened, and extended family needs to be screened for carrier state. The females in the family might be carriers. So this is our IVIG prophylaxis sheet, which we give to our patients. When we give IVIG to them, this prophylaxis IVIG sheet is filled up, the rate is filled up, and we keep it with us. And we look at the IgG trough level, and somewhere down the line, when we know that the trough is not enough or not maintained, or the child is having recurrent infections, then we need to have a higher trough level. We would increase the dose. So this is regarding the bleach bath. There are so many children who come with MRSA, sepsis, infections. So this is a bleach bath. This is something which we give to, which hand over to our kids with hyper IgE syndrome or Docket deficiency, and they follow this, and we tell them very categorically that it has to be pretty mild. So you can see that ala bleach is 4% sodium hypochlorite. It has to be added to 20 liters bucket of water. 2.5 ml of this to be diluted in 20 liters of water. This is the simplest thing which we could hand over to one of our patients with Docket deficiency, and he responded pretty. So there are inborn errors of immunity which are associated with Staph aureus infection. So you can see this. So in these children, irrespective of the diagnosis, when a child comes with a recurrent multiple abscesses, recurrent infections, which are MRSA, we need to do a MRSA nasal swab of the patient as well as caregivers. Okay, and decolonization protocol needs to be followed up for getting rid of MRSA carrier state. So this is a CDC guideline which tells us about the horizontal infection control strategies as well as vertical infection control strategies. These infection control strategies reduce the MRSA transmission to other patients, but they are not pathogen specific. These include hand washing, you wearing the gloves, to cap, mask, and also to wear an apron when you are dealing with such patients. And the vertical control strategies include active surveillance testing for high-risk patient populations. The high-risk patient populations are immunocompromised patients. Like even if it is post-chemotherapy, even if it is a primary immune deficiency or it is an acquired immune deficiency, we need to look at specific pathogen. So acquired immune deficiency need not be AIDS. We have CD4 lymphopenia, which is also acquired in nature and comes over a period of time. So CD4 lymphopenia, many a times we don't have a genetic diagnosis for it, and they can present at 34 years of age with recurrent infections, which are both T and B specific. So they are late onset combined immune deficiency. So they are also active surveillance we have to do. Decolonization for patients colonized with MRSA or at high risk of infection. So this vertical and horizontal strategies combine together offer maximal benefit. So why is source control important? Source, mother might be a carrier, but the child will get infected because the child is immunocompromised. It reduces the burden and burden of the patient's skin contamination, decreases the contamination of healthcare professionals also, and decreases the spread of potential pathogens. Okay. So MRSA prevention strategies include chlorhexidine gluconate bathing at home and also in the intensive care units when the baby is admitted. MRSA decolonization therapy includes intranasal antibiotic or antiseptic application. We commonly use mupirocin at night and we continue it for 1 week, and then we repeat the MRSA carrier status of the mother or the caregiver. Active surveillance testing for MRSA prevention and universal gown and glove use in ICU and also at home if you think that the child is severely immunocompromised. So this is an SOP for prophylaxis and primary immune deficiency, which we hand it over to most of our patients who are diagnosed or who are suspected. All suspected primary immune deficiency children should receive irradiated blood and blood products. There should be no live vaccines given till the diagnosis is received. Prophylaxis depends on the type of immune deficiency, and multiple reiterations to the prophylaxis is needed for these patients. So what is very important here is antenatal counseling. If we have an index patient, these parental studies are very important. What we call is Sanger sequencing. So unless we identify if the homozygous status of the patient is because of these parents, they need to be studied, and we have to tell them that they have to undergo prenatal testing when the mother conceives subsequently. And prenatal testing can be done before 10 to 12 weeks or at 15 to 16 weeks as convenient to them. Prenatal done for more than 60 families in our cohort. And we have seen that the total ANC with affected children, 36 patients, fetus with the carrier status was 8. So the child had a carrier status, but the child was not affected. Fetus affected with genetic defect was only 6, and fetus unaffected was 23, which is very heartening to see that we have more of unaffected patients. So we actually, that is how we end up counseling them for prenatal diagnosis. So what about vaccines and primary immune deficiency? There are multiple vaccines which we should not give. The live vaccines should not be given. No BCG, no OPV, and rotavirus should also be avoided. BCG, OPV, whenever they come for a regular polio drive, should be avoided. We have to give them a letter that it should be avoided. Killed vaccines can be given, but usually we give the killed vaccines only when we are doubly sure that we are not missing out on something. Do not give rotavirus or OPV to other children in the household as well. As I told you, these children will be the carrier for infection and recurrently reinfect our index child who is immunodeficient. So no rota or OPV to other children in the household. Varicella is also a live vaccine. MMR is also a live vaccine, should not be given. pneumococcal, meningococcal, and influenza being killed vaccines can be given. Now, coming to autoimmunity, you think autoimmunity is an inborn error of immunity? This is the history. This is an 11-year-old boy who was initially diagnosed with autoimmune hemolytic anemia and he responded to steroids. At 14 years, he had severe thrombocytopenia and he responded to IVIG. So that's an immune modulatory mechanism. So then naturally it was immune in origin. Then he developed at 18 years an alopecia areata. He developed a keratoconjunctivitis subsequently, and he was being treated by the rheumatologist after he went to him because he had fever, rash, oral ulcers, arthralgia, bilateral knee, and he actually was falling into an SLE Euler criteria. He was managed with hydroxychloroquine and steroids. But then he went on to develop more autoimmunity, and that is how he reached us. And we ended up diagnosing him as APDS syndrome or PI3 kinase delta syndrome. And this boy, we referred him for transplant, but they did not want to get transplanted. And he was started on sirolimus, and he is doing pretty well. He has actually finished physiotherapy, the third year physiotherapy, and he's going to Canada. He is on sirolimus right now. So for all the children who with inborn errors of immunity, we give this do and don't paper, which is self-evident. They can go through it. There are drawings, so there are figures there, and there is written material also. So those who cannot read English, at least the figures are self-explanatory. And we also give our phone number so that if they have any query, there is a WhatsApp number also. They can get in touch with us. So for our nursing staff, the standard precautions in patient care, that is universal precaution, we have to follow. Always remember, we need to use double gloves as infants are HIV ELISA negative, and HIV PCR is not commonly asked for. Many of our children who were primary immune deficiency, but later on turned out to be HIV PCR positive also because of multiple reasons. Mother was probably in a window period when she was tested for HIV, and she also subsequently turned out to be HIV positive, and this baby was HIV PCR positive as well. So we need to be very, very careful about it. The risk of transmission of skin infections like molluscum contagiosum is pretty high, so gloved hand is very important. Cross contamination can be prevented with a gloved hand. Difficult IV access and phlebitis and LED, so PICC is better. You can be a carrier and your family is at risk too, which is a professional hazard, so please take care. So this is for my colleagues who are from the nursing fraternity. Always look at the CBC, and if you see that the patient is pale, send a reticulocyte count as well. Peripheral smear to hematologist is a window to many, many diagnoses. Many things get picked up, which includes the platelets, which are like dust, like Dr. Purva was telling you that. So they'll pick it up. Coombs before PCV transfusion. Many autoimmune conditions get diagnosed once DCT becomes positive. Immunoglobulin levels before starting any chemotherapy, because we don't know who is harboring the gene which is responsible for that malignancy. Any unusual behavior of disease process needs further probing. Last but not the least, acumen of nursing staff often eases most difficult scenarios. We stand on the shoulder of giants. Dr. Zanet Karimboy started this department of immunology. She was a visionary whose perseverance laid the foundation of this all-encompassing branch. My mentor, Dr. Mukesh Desai, his knowledge is as vast as the ocean, and every day with him is a new learning. Department of Pediatric Hemato-Oncology and Immunology at Vadia Hospital. Together, we achieve more. And this is Department of Immunology and my colleagues with Dr. Mukesh Desai and Prasad, who is a scientific officer and pillar of our department, and all our patients, without which we wouldn't have learned what we have learned today. Thank you so much.
Thank you, Dr. Vijaykumari. It was again a detailed session. Thanks for highlighting the do's and don'ts. We don't find any questions or suggestions on the chat box. If there is anyone having any question, please post. Meantime, I would like to ask you regarding the IVIG infusion. So IVIG infusion. Yeah, so IVIG infusion in your hospital. So what are the precautions that you take, and how common do you come across allergies or any reactions with IVIG
If there are
in
any
children
questions,
with
we
this
would be
variant?
happy to take.
Purva, can you hear me? Purva, can you hear me? Dr. Purva and Vijay Gauri, can you hear me now? Is there any other participant who can hear me? Purva, can you hear me?
Yeah, we can hear you, ma'am.
Yeah, I think they have some issue probably.
If there are no questions, can we, Dharani, can you,
Yeah,
should we
can
end
you
the
hear
meeting?
now?
There are no questions.
Dr. Vijaya, can you hear me? Can you hear me? You're not able to hear me.
We can't hear you.
Yeah, I think you all have some issue
Can't hear you, right?
We'll send.
because others are hearing, you're not able to hear. Can you now?
Yeah. Yeah, you?
Yeah. So I don't find any questions on the chat box. Thank you so much for the comprehensive session.
I don't know, for some reason we can't hear you.
Yeah.
I can hear you now. I can just 1 second, maybe. Yeah, yeah. Okay. We can hear you now,
Sure.
Dhar.
That's great. That's great. So thank you so much for the detailed discussion and topics. So I don't find any questions on the chat box. Just one quick question. How common do you come across any reactions during IVIG infusions in such children?
So it's pretty rare. See, normally when we are giving it for the first time, we go little slow and we finish it over 6 to 8 hours time. But subsequently, when these kids are coming to us every month, we give it over 4 hours because we have a shared daycare, both hemato-oncology as well as immunology. We have a shared daycare. So there are a lot of the beds are very important for us. So we give it over 4 hours time. In case the child has got any kind of a reaction, we keep Aval and paracetamol in hand and give it to them. But usually there has been never a major reaction. Never a major reaction. We have completed a
That's
1 hour
fine. So I know
phase 3 clinical trial also, and none of them had any kind of reactions.
fine. And do you use subcutaneous IVIG? I mean, immunoglobulin or only IV?
IV, because our parents and children are not very intelligent to use it. And the cost is also, it's not very cheap. Hygiene has to be maintained and we cannot trust them. Most of them are coming from a low socioeconomic strata. So we have not had the guts to start as yet.
Understood. Okay. Anyway, with that, I really thank you so much, both of you, for being there and having a comprehensive talk. And I thank you both on behalf of all the nurses who have joined. And sincere thanks to all the delegates who have stayed till the end. Thanks to Echo platform for this session, and we will close the session. Thank you.
Thank
Thank
you
you
so
so
much.
much.